I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, we interview Dr. Katherine Warburton on mental health diversion and preventing criminalization of mental illness. Dr. Warburton is an associate clinical professor at UC Davis. She is also medical director at the California Department of State Hospitals. Welcome.
Thank you.
Dr. Warburton, could you share with us more about your role as medical director at the California State Hospitals?
Sure. We have a hospital system that's over 6,000 beds. Data from around 2014 indicated that in California, we treat 37% of all the inpatient forensic patients in the country. So we have a very large system, and it's mostly forensic in nature. Only 8 to 10% of the patients we treat are sent to us as civil commitments. Just by way of a little bit of background, my interest has always been working with individuals who have schizophrenia, and that led me into the field of forensics because of guidance I received in research I did when I was a resident indicating that individuals living with schizophrenia who are experiencing criminal involvement and subsequent trajectories such as forensic inpatient hospitalization or incarceration. And so I find myself here in this very, very large forensic hospital system trying to understand that trend.
That would lead me to my next question, which is, could you explain a little bit more about what diversion is and how that process works?
Sure. I think I would like to provide some context to diversion first. Our patient population here at the California Department of State Hospitals is experiencing massive increases in the number of individuals referred to our hospitals as incompetent to stand trial on felony charges. So these are individuals, for the most part, who are living with the disease of schizophrenia, who are having more and more criminal justice contact to the point where they are arrested on a felony charge. And then when they get involved in the criminal justice system, someone identifies that their psychotic symptoms as a result of their schizophrenia are preventing them from being able to stand trial. So while the prevalence of schizophrenia has not increased, the number of people with schizophrenia who are being arrested on felony charges and eventually sent to us as incompetent to stand trial has increased remarkably. And as I mentioned, this is happening all over the country and really kind of causing state hospitals to become unable to accommodate all the referrals that we're getting for these individuals. And so state hospitals around the country right now are really struggling with this influx. We have a research partnership with the University of California at Davis. Dr. Barbara McDermott is the research director in this partnership, and she's been studying this population for over a decade. Really, for every IST admission that's admitted, a significant portion of those are looked at by her research team in terms of various variables, everything from where they're coming from, the level of symptoms that they have, the number of prior arrests that they have, what their diagnosis is, et cetera, et cetera. And she was able to find some remarkable things about the changes in this population, because we've asked her, why are these numbers increasing? What's going on that we're seeing more and more individuals who have the disease of schizophrenia spectrum illness getting arrested on a felony charge and eventually finding their way to us? So a few things that she was able to tell us from the data is that the number of individuals that we're admitting, the percentage of people who have had 15 or more previous arrests has increased from about 15% of our overall admissions to around 45% of our overall admissions. So one thing that we know about the population coming into us is that they're having more and more and more criminal justice contacts. When we look at those, we take a look at the arrest reports. We noted that oftentimes the arrest is related in some way to either untreated symptoms of psychosis, conditions of homelessness, or conditions of poverty. So when we took a look at all of that information, we then asked her to look at the issue of homelessness, and she did another 2-month look at virtually every single admission that we did in those 2 months. I think it was almost 400 people she looked at. And she came back around and let us know that 47% of the individuals that we're admitting are in an unsheltered homeless status at the time that they're arrested. And, we're state hospitals. We're not community based in most ways. We're running our hospitals and trying to take the best care that we can of people. But we are also sort of helplessly watching this trend of increasing referrals of individuals who we now know have, almost half are in an unsheltered homeless condition, and they're experiencing increasing arrests. Dr. McDermott was also able to do a data use agreement with partners in a different state agency that track Medi-Cal data. And, to put it in simple terms, 47% of the individuals that were admitting as incompetent to stand trial did not access Medi-Cal reimbursable mental health services in the 6 months prior to their arrest. So we now know we have individuals primarily living with schizophrenia spectrum disorders, really schizophrenia and schizoaffective disorder, who are untreated, who are unsheltered, and who are getting arrested more and more and more. And so we started really looking at the police reports, asking ourselves, well, what's going on? And in so many cases, the general story is an individual is experiencing psychotic symptoms that are driving a certain behavior. That behavior is distressing to people around that person. That person is in an unsheltered homeless condition, so they're generally evidencing those behaviors in some sort of public area. And when the police are called, because that individual is, experiencing delusional symptoms, oftentimes paranoid, sometimes persecutory, there's oftentimes an event after the police are called that becomes violent in some way, and then that person is charged with a violent felony, sent to us as incompetent to stand trial. So we kind of have a better understanding now of what's going on with these individuals that are driving them into our hospitals. But one of the things that makes us feel very helpless is that a state hospitalization for restoration of competency is a very focused, expensive hospitalization that is only geared toward making sure that that individual understands the proceedings, the court proceedings, and that that individual has the ability to cooperate with their attorney. And once those two goals are met, we are statutorily obliged to send that person back to court to face the charges. Sometimes those charges are dismissed and they're sent back to the same situation that they were in that caused the whole process to begin in the first place. That is an untreated, unsheltered situation. Or sometimes they're incarcerated. And so we have, I run state hospitals. My whole life's passion is working with people who have schizophrenia, but it's a very helpless feeling to know that you've got these ever increasing numbers of human beings coming through your doors, and you're not really doing anything in the course of their hospitalization that's going to change the trajectory of their illness. You're just essentially restoring them to competency and sending them back to a untenable situation that does nothing for their long-term biopsychosocial needs. So that's when we became involved in diversion. And fortunately, diversion is a very well-studied, well-elucidated concept. And there are lots of national policy groups and policy leaders who have been for, I don't know, the last 15 years, 20 years, really writing about and studying the idea of how do you divert an individual with serious mental illness from the criminal justice system. So I would encourage listeners who are at all interested in this to read. I mean, you can just Google it and find policy papers from people like Dr. Hank Stedman, who is, I think, sort of the leader in this for many years. So it's essentially a process whereby a community can map all the various points where an individual who has a serious mental illness comes in contact or potentially would come in contact with the criminal justice system, and those are called intercepts. And then a community with all the stakeholders in that community puts interventions in place at each one of those intercepts to try to divert that person away from the criminal justice system and into treatment. So here at state hospitals, we were given some money in the budget last year to try to reverse the trend of individuals with serious mental illness coming in on felony charges to our hospitals. So we've been working with communities to really get folks at the intercept where they've been charged with a felony, they're in jail, but they've been identified as someone who has a treatable illness, who has, with treatment, could be safely treated in the community, and who has a significant relationship between their symptoms of mental illness or homeless status and the crime that they committed. So those kinds of cases I was telling you about where really the arrest stemmed from their conditions of psychotic symptoms and unsheltered status more than any kind of criminal intent. So we've been working as a Department of State Hospitals with various counties in California to get some of these what are called post-booking pretrial diversion programs going, with the hope that if we can get people diverted at that intercept, we will divert them away from this competency restoration process, which we have understood to be, not really helpful in the long term for reversing this trend.
Wow, thank you for sharing such great information with us. With that being said, can you speak to the status of diversion just in general, diversion efforts within California? Where does California stand?
There is a national initiative through the Council on State Governments, CSG is what they call themselves, called Stepping Up. A visit to the Stepping Up website is extremely informative in terms of counties in California and across the country who've sort of made a commitment to stepping up to divert people with serious mental illnesses from the criminal justice system. So that's a good place of information. I think there are a lot of California counties that have engaged in the Stepping Up initiative, and they're in all sorts of stages. The first step that a community has to take for diversion is to really get all the key stakeholders together. And from what I've read and what I've heard anecdotally from successful diversion counties around the country, is that's the hardest part, is getting all the various, the sheriffs and the public defenders and the district attorneys and the county administrators and the county behavioral health and the local police departments, everyone at the table and sort of rowing in the same direction. And then the next step is to do what's called mapping, where you sit down all together and you identify where those intercepts are. And then you have to find the resources to put in programs at those intercepts to result in the diversion. And then you have to get those programs up and running once you get the resources, and then you kind of have to measure the level of success. So I think, various counties who have stepped up are in various stages of that process. I would say one county that has just been particularly impressive to me, just as a citizen of California watching, is LA County. The Office of Diversion and Reentry that they've created in LA County. I think if you Googled them, you could find some of their information, and they have a really moving YouTube video showcasing their program down there. But they've really kind of, brought their stakeholders together. They put out a policy paper. They created this whole office. And I went and I sat in their courtroom one day and watched the diversion court in action. And it was very inspiring. And there's pockets of that kind of excellence all over the state.
What kinds of crimes are we talking about that will typically occur due to mental illness? Can you share some of those with us?
That's a very broad question. I think and diversion can happen sort of with any type of crime. So low-level misdemeanor crimes can be diversion candidates. Our particular program is focused on felonies. So a lot of the felonies we see are criminal threats or robbery or assault. But what we're really trying to target are not those cases where those crimes are committed due to criminal thinking or criminal intent, but more cases like the one I described where because an individual is in an unsheltered, untreated condition, their behavior causes disruption, and then because they're afraid and paranoid, they sort of act out violently when someone comes to try to contain that behavior. So those are really the folks that we're hoping to target with the uh, post-arrest pretrial diversion, felony diversion. But really, diversion can happen in many types of crimes with many types of mental health pictures. There's also diversion, and this is, not in any way my area of expertise, but they have veterans diversion courts and diversion for people who have substance use disorders and other things. So diversion is broader than just mental health diversion, and mental health diversion is broader than just our program. And our program is really focused on this particular population that's washing into our hospitals.
Okay, so that brings me to my final question, which is what types of earlier interventions are there for mentally ill persons who've committed a crime prior to prosecution, conviction, and incarceration? And with that being said, could you share with us a little bit more about how the crisis intervention team policing works?
Sure. And this is really ideal. So if you look at the continuum of intercept points for individuals with mental illnesses, you really want to intervene as soon as possible. You really want to get down to, even before the police are called, having some sort of mental health team in the community. Models I've seen that are very successful is to have something like a diversion center, which is a place where an individual can be taken or go to that has connections to a variety of mental health services, everything from, outpatient appointments to inpatient beds, so that if an individual is experiencing mental health symptoms in the community, even before there's criminal justice contact of any kind, they're brought to a diversion center. Crisis intervention training is kind of the next level of that, which is where the police are involved, but they're a very sophisticated, educated police force who've been trained in recognizing individuals with mental illness and knowing when to take that individual to a diversion center or to mental health treatment rather than arresting that person and bringing them to jail. And that was something it's called the Memphis model sometimes. And I think in general, it's a 40-hour training curriculum for the officers to kind of become mental health experts themselves so that they can make those distinctions and know how to interact with that individual to keep the situation under control, if you will.
I think that's excellent. Well, thank you so much for sharing such valuable information with us and love what you do. Thank you for being on the show. Thank you so much.
Oh, thanks for having me.
This podcast was brought to you by NEI membership. You're busy caring for your patients, and you might not have time to keep up with the ever-changing treatments in mental health care. You don't have to. NEI membership includes regular psychiatric news updates, CME activities on the hottest topics, and the most cutting-edge prescribing app available today. To learn more, visit the link provided in the podcast description.